This session will be based on just the general things about tonsillectomy. So if you start reading tonsillectomy, the first thing which will come is the indications. We can divide the indications into absolute, relative, and as a part of any another operation. If you see absolute, it is very easy, and there are 5 absolute indications of tonsillectomy, starting with recurrent infections of throat. Now, you can remember it like a story. A patient suffered recurrent infection of throat, upon which no treatment, which resulted into peritonsillar abscess. This peritonsillar abscess and tonsillitis then caused febrile seizure. So, 3 indications have been found by the story: recurrent infection of throat resulting into peritonsillar abscess, more serious, and resulting into a more severe form, that is febrile seizures. Then, fourth indication is hypertrophy of tonsils causing obstruction, and the definite absolute indication is suspicious of malignancy. So, 5 absolute indications which are very much important are recurrent infections of throat, peritonsillar abscess, tonsillitis causing febrile seizure, hypertrophy of tonsil causing obstruction, and suspicion of malignancy. Relative ones are relatively easier: diphtheria carriers, streptococcal carrier, recurrent streptococcal tonsillitis in a patient with valvular heart disease, and a chronic tonsillitis with a bad taste or halitosis forms the relative indication. As a part of operations like palatopharyngoplasty, glossopharyngeal neurectomy, and removal of styloid process. Now we'll see what do you mean by recurrent infections of throat. Recurrent infections of throat, we mean that there should be 7 or more episodes in 1 year, 5 or more in 2 years, 3 or more for 3 years, or 2 weeks or more of lost school or work in 1 year. So the number comes 7, 5, 3. So 7 in 1 year, 5 in 2 years, and 3 in 3 years, or 2 weeks or more of lost school or work in 1 year. Peritonsillar abscess. So tonsillectomy is done usually 4 to 6 after this abscess has been treated, and in adults, the second attack of peritonsillar abscess forms one of the absolute indication. Tonsillitis causing febrile seizure, hypertrophy of tonsil causing airway obstruction, difficulty in deglutition, and interference with speech. So just hypertrophy won't do. That must be causing some problem like airway obstruction, difficulty in deglutition, or interference with the speech. Malignancy, when you will suspect that the tonsil may have a malignancy. So any unilateral enlarged tonsil may be a lymphoma or a epidermoid carcinoma. So you must do a excisional biopsy, that is remove the tonsil by tonsillectomy. Relative indications you already know: diphtheria carrier, streptococcal carrier, bad taste or halitosis, and recurrent streptococcal tonsillitis in patients with valvular heart disease. Palatopharyngoplasty for sleep apnea, glossopharyngeal neurectomy, where the tonsil is removed first and then the glossopharyngeal nerve is severed, and removal of styloid process. Now, contraindications. So any surgery which you do before indications, you must know what are the contraindication, when you should not do surgery. So if your patient having all the indications but hemoglobin level is less than 10 gram percent, as one of the complication is hemorrhage, you shouldn't do this surgery. Acute infection in upper respiratory tract or acute tonsillitis, so because bleeding is more, so you should avoid. Children less than 3 years of age, overt or submucous cleft palate, bleeding disorders. So bleeding is complication, any bleeding disorder at the time of epidemic of polio. Uncontrolled systemic diseases like diabetes, cardiac disease, hypertension, asthma. And the anesthesia we do is general anesthesia. In adult, it may be done under local but shouldn't be done. Position is rose position. In this, both the head and neck are extended, and this is the figure showing you rose position. So advantages is the risk of aspiration is less, both the hands of surgeon free and surgeon can be comfortably seated at the head end. Boyles-Davis mouth gag is used to open the mouth and get access to the tonsil. It has one tongue blade and the mouth gag, that is the Davis mouth gag and Boyle's tongue blade. So here you can see the figure of Boyles-Davis mouth gag. Steps of the operation you already know. We introduced the Boyles-Davis mouth gag, and tonsils is grabbed and pulled medially, incision made in the tonsillolingual sulcus and extended along the upper pole to the mucous membrane between tonsil and the posterior pillar. Then, with dissection is carried out in the tonsillar fossa, and the tonsil is held at its upper pole. Traction applied downward medially. Dissection continued until the lower pole is reached, and getting at lower pole, a wire loop of tonsillar snare is threaded over the tonsil, pedicle tightened and held for some seconds, some minute, and then the tonsils is removed. A gauge sponge is placed in the fossa and pressure applied for a few minutes. You will look for the bleeding point and tie it with the silk. Then you go for the other side. Now, immediate general care. So post operative care in this surgery is very important. So immediate general care, what you will do, you will make the patient in coma position. That means either left lateral or right lateral until fully recovered from anesthesia. So keep a watch of bleeding and check for the vital signs. Diet: when the patient is fully recovered, that is after 5 to 6 hours of GA, he is asked to take cold liquids like ice cream, cold milk, and sucking of ice cubes gives a relief. So cold things are preferred and mainly liquid for that day. Diet is gradually built from soft to solid food, maybe like custard, jelly, soft boiled egg, slice of bread soaked in milk from the second day, and plenty of fluids should be encouraged. Oral hygiene should be maintained. Condies or salt water gargles 3 to 4 times a day. Mouthwash with plain water. So oral hygiene is very important. Otherwise, it will result in a second complication, that is infection. So analgesia: patient must be having pain, so you should give adequate analgesia and antibiotic for the patient. Now, methods. There are several methods, most commonly which a resident learns in his residency. First is the dissection and snare method. Guillotine method is also another method, but nowadays very less done. Intracapsular, harmonic scalpel, plasma mediated ablation technique, and cryosurgical technique. Hot are electrocautery by bipolar, laser tonsillectomy, coblation tonsillectomy, radiofrequency, among which coblation tonsillectomy is most preferred nowadays. Other methods of tonsillectomy we have already discussed: guillotine, electrocautery, laser, and intracapsular tonsillectomy. So microdebrider is also used. Harmonic scalpel can also be used. Plasma mediated coblation tonsillectomy, this is the coblation band which is given. Cryosurgical technique using the cryosurgery, that is minus 82 degrees of carbon dioxide or minus 196 degrees centigrade of liquid nitrogen. So this is the one used for cryosurgery. Coming to the complication, which is the most important section of tonsillectomy, we can divide it into immediate and delayed complication. Among immediate, first, any bleeding which occurs before 24 hours is primary, and any bleeding which occurs after 24 hours is secondary. So it has changed little, and now reactionary is not there in the classification. So primary hemorrhage can be controlled by pressure, ligation, electrocoagulation of the bleeding vessels. What else? Immediate complication can occur due to bad technique. Surgeon can injure the tonsillar pillar, uvula, soft palate, tongue, or superior constrictor muscle. That means the nearby structure to tonsil. Injury to tooth may occur while you apply the Boyles-Davis mouth gag. Aspiration of blood can occur if you have not given throat pack adequately, or there is the rose position is not maintained. Facial edema in some patients, and surgical emphysema due to injury to the superior constrictor muscle rarely. Delayed is the secondary hemorrhage. So simple measures like removal of clot, topical application of dilute adrenaline, hydrogen peroxide may help, and in sometimes general anesthesia need to be given to ligate or electrocoagulate the active bleeding vessel. And sometimes we have to approximate the pillars with the mattress suture. And in serious cases, external carotid ligation may also be required. So you must be ready with the blood transfusion, plasma transfusion, depending upon the blood loss, and systemic antibiotics are given to control infection. So hemorrhage has been done. Now other delayed complications are infection, lung complications like aspiration of blood, mucous tissue fragments, scarring in the soft palate and pillars, tonsillar remnants which are left like tonsillar tags, tissue left during inadequate surgery. So these were some of the other complications of delayed complications of tonsillectomy. Hemorrhage, you already know. Second is infection can occur. Then lung complication can occur. Scarring in the soft palate and pillars can occur due to manipulation or injury during the surgery. Sometimes tonsillar remnants are left which may get repeatedly infected, and there can be hypertrophy of lingual tonsil as a compensatory mechanism for loss of palatine tonsil. So sometimes lymphoid tissue is left in the plica triangularis near the lower pole, which later gets hypertrophied. So plica triangularis should be therefore be removed during the tonsillectomy. So this was the basic general idea which is frequently asked in your examinations during your viva for tonsillectomy. Thank you. What else you should read? You should read the vascular supply, that is blood supply of tonsil, its anatomy, which I have not discussed in this presentation. So this was the very short 2 minutes video for the, not 2 minutes but 12 minutes video for the tonsillectomy. Hope it had helped you. Thank you.